Hi, I'm Dr. Craig Dimitris. I'm one of the hand and upper extremity surgeons here at Orthopedic ONE. I have fellowship training in surgery from basically the clavicle or collarbone to fingertip, and so that's where the majority of my patient focus is. I practice out of the Grove City and Hilliard offices. I'm going to talk to you today about carpal tunnel syndrome, one of the most common things that I see in the office. Carpal tunnel syndrome is the most common nerve compression seen in the upper extremity. It's a pinch of what's called your median nerve or carpal tunnel nerve down by the wrist. The anatomy of it is if we were to take a cross section of your wrist and take a slice through the middle of your wrist and look at the end of the wrist, you'll typically see bones on three sides and a thick bristle tissue that forms the roof. And in some people, that tunnel is too tight. The predominant symptoms of carpal tunnel are usually numbness and tingling and pain in the hand. Patients most commonly will complain classically of numbness and tingling in these three fingers, the thumb, index, middle finger, and often part of the ring finger. Occasionally, patients come in and say, my whole hand feels like it goes numb when I sleep. And typically, I ask them to pay close attention to the pinky finger, which is typically not involved in carpal tunnel syndrome. Symptoms tend to be worse at nighttime while you sleep because most people sleep with our wrists curled up, and that tends to exacerbate symptoms. And so patients often say, yeah, I wake up at nighttime and have to shake my hand out to try and get sensation back to my hand or feel like I'm getting the circulation back to my hand, even though it's not really a circulation problem, it's a pinched nerve problem. Other common things that bother people are driving or gripping a mouse or keyboard, holding your phone where we tend to hold it up to our ear with an extreme motion to our extreme flexion to our wrist in order to hold in that position. Things where you're holding your hands steady, like reading a book or reading the newspaper, can cause symptoms. Things that vibrate, like using a lawnmower, riding a motorcycle, or using a hairdryer, also tend to make symptoms worse. Common risk factors for carpal tunnel can be several different things, both health history-wise and otherwise with our lifestyle. Age tends to be a risk factor, so as we get older, carpal tunnel tends to be more common, though it can happen to people of all ages in life. And really, I've seen it in patients in their teens all the way up through their 90s. Certain medical conditions like diabetes or hypothyroidism predispose you to getting carpal tunnel, but you don't have to have those things. And the majority of patients I see with carpal tunnel don't necessarily have some other risk factor. It's more common in women who are pregnant, but tends to resolve after pregnancy. Women who have carpal tunnel during pregnancy are more predisposed to getting carpal tunnel later in life, though. One of the more commonly held myths is that things like typing cause carpal tunnel syndrome, and that's been studied, and some studies support that. Many studies seem to debunk that myth as well, and so we don't think that typing has as big of a causative factor on carpal tunnel as we thought it used to. Carpal tunnel syndrome is typically diagnosed clinically, meaning your symptoms in your physical exam are the most important factors in determining who has carpal tunnel syndrome. Most of the time, we'll offer patients electrodiagnostic testing, what's called an EMG or a nerve conduction test, where a physician does a special test putting pins and needles into the skin and muscles to check the speed of the nerves in the upper arm. That test can aid in the diagnosis by making sure it's just carpal tunnel that's going on and not other nerve compressions. It can also help grade the carpal tunnel, telling us, is it mild, is it moderate, is it severe, which helps give a more clear prognosis as to what would happen with certain treatments for carpal tunnel. Patients typically have numbness and tingling in those fingers to light touch. They'll have, sometimes if it's really advanced, some thinning of the musculature called atrophy of these muscles, as those are also driven or powered by the carpal tunnel nerve. Patients will have certain maneuvers we do to their wrist that causes or exacerbates the pain or numbness and tingling. And those are really the physical exam findings that help in the diagnosis of carpal tunnel syndrome. Treatment options for carpal tunnel syndrome. I tell patients I think three things really help with carpal tunnel. In people who have borderline to mild carpal tunnel, wearing a brace at nighttime can be very helpful. The brace has a rigid shank in the palm of that brace that stops you from bending your wrist. So a lot of people who have nighttime symptoms, and even people that have daytime or morning symptoms, because they're sleeping all night with their wrist curled up, by keeping that wrist nice and straight during the nighttime can improve those symptoms. Once people get to moderate or more severe carpal tunnel, where they're having symptoms more commonly throughout the night and throughout the day, bracing will often help with their symptoms, make their night's sleep a little bit better, but not fully resolve their carpal tunnel. The other treatment options at that point for carpal tunnel syndrome that I think make a big difference are cortisone shots or steroid shots to the wrist. Those act not by changing the carpal tunnel shape, but they make the stuff inside less swollen. So a steroid shot's an anti-inflammatory. It makes the stuff inside the tunnel less swollen, which decreases the irritation of the nerve. 4 out of 5 people with a cortisone shot for carpal tunnel get better with this shot, but only 1 out of 5 are better at a year. So it tends to give patients temporary relief, sometimes measured in weeks, most often measured in a couple months. I'll commonly offer patients cortisone shots in situations where they have a busy time at work or there's something important in their life that's coming up, where now is not a good time to talk about the third treatment of carpal tunnel, which is surgery. Surgery is the most definitive treatment for carpal tunnel. It can be done one of a couple ways. One is with a small incision in the palm, another is with a small incision back by the wrist. But the goal of carpal tunnel surgery is to open up that thick gristle tissue that forms the roof of the carpal tunnel. That decompresses the nerve and relieves the pain in the hand and wrist, improves the numbness and tingling in the fingers, and usually makes patients' symptoms better over several weeks to several months' time. Expectations after carpal tunnel surgery should be improvement in patients' symptoms. I often tell patients that pain and nighttime symptoms get better first after surgery. Those are frequently what brings the patient in. They've often had numbness and tingling in the fingertips for a while, and once it starts becoming painfully numb, that's when they come in to see me. Those symptoms, therefore, often resolve faster than the numbness and tingling do. So patients will come back to the office in a couple weeks to get their stitches out, and they'll say, I'm sleeping better at night. I notice the pain is a little bit less. My arm is burning less. My hand feels less stiff or swollen in the morning when I wake up. So patients typically notice some change in that first couple weeks. It's very rare for patients to say, I'm instantaneously better, or the next day I felt dramatically better and all of my symptoms were gone. Typically, patients' symptoms have evolved over several weeks or months or years, and so it doesn't get better like flipping on a light switch. It typically takes many months for patient symptoms to fully resolve. Typically go home that day and you ice and elevate your hand for the first couple of days after surgery. You have a big dressing on your hand that you change after a few days, but from day 1 on, you're using your hand to do light stuff. I tell patients they're typically able to type on their phone right away. They can pull their pants up and help dress themselves and feed themselves from the day of surgery on. Patients typically have soreness in the palm of their hand where the actual surgery is. Anywhere from 2 to 6 weeks after surgery is most common. Patients will have that dressing changed by themselves before they see the doctor back in the office, and then typically get their stitches out somewhere in the 10 to 14 day range. And most patients by that first post-op visit already say they're doing about 50% of what they normally do with their hand. Patients should expect to be back to light duties around the house within a couple of days. Very motivated patients can go back to work with office type work within a couple of days, though most people take off about a week. People who have really rigorous jobs that involve a lot of lifting, pushing, pulling often are back to work in the 4 to 6 week range. And patients should expect to be back to most normal activities by 6 to 8 weeks after surgery. Numbness and tingling resolves in the fingers in most patients over several months up to a year.